cardiac ultrasound is probably where the pre-hospital POCUS shines the most. And you can study it, you can see these really good images, and then you go to try to get an image on a patient.
You just dove in. You didn't even say, welcome back to the Foam Frat podcast.
Oh, shoot, you're right. I know. I'm trying to mix it up a little bit. All right, let's...
It takes me off guard. I mean, keep going. But I just think that people will probably think they're listening to the wrong podcast right now. No, go ahead.
Welcome back to the Foam Frat podcast.
Now I feel comfortable.
The guest today is Peter Weimersheimer. He is a physician and he's an educator for Butterfly. And I made a video comparing the Philips Lumify with the Butterfly. And then before Butterfly, I sent it to them just to make sure I didn't say anything wrong or whatever. And they had Dr. Weimersheimer take a look at it. And so that's how we started communicating. And I saw him do a lecture at Castlefest years ago on cardiac ultrasound. And he did a fantastic job of just breaking it down, how we're bisecting a cone and how your best images are when they're perpendicular to the structure, your target structure. And so I wanted to have him on and do an interview with him. And if you've been in that situation, like I was describing in the beginning, where you want to try to get those textbook images, but it's a little bit harder, he's got some excellent tricks. So, Sam, you listened to the episode. What'd you think?
Yeah, well, obviously I'm no ultrasound guru, but I thought I could add maybe a little bit to this because I noticed what my brain was doing during the whole podcast. And I kind of pride myself on being able to learn something efficiently, which is kind of like a skill in and of itself. And so while I was watching this, I'll just use I think one of the first ones you guys talked about was the parasternal long axis view. And anytime I have a skill or I'm watching a video on something, and it's kind of a long process or it's kind of complicated, I like to try to put it into chunks or like micro skills as much as I could. So when I was listening to you guys, I was thinking like, what is the first thing? What is the second thing? And so with the parasternal long axis, for example, you guys talked about the location. So it's like if I broke this down to 5 steps for beginners, and I notice it as you guys are watching the interview, it's like location. It's like, okay, I know where I'm going. I know the left sternal border right here. And we talk a little bit about orientation. And so the probe marker should be faced over here towards the right shoulder. And then it's like gel. And so I just think about those steps. It's like location and orientation. I'm going to need a lot of gel apparently. And then I can start to slide here from the clavicle and work my way down. When do I stop? When I see something dark, that's going to be like the ventricle, and then I'm going to rotate a little bit to get it. And so whole processes can seem kind of like daunting, especially if it's something like ultrasound and imaging and stuff like that. Especially if you're not familiar with it, which I'm not very familiar with it. And so it reminded me a lot of music. And I think about you and I share guitarists or music that we see on YouTube or something like that. And sometimes you want to learn it, and at first it seems impossible because there's all these steps and you look at this whole piece of music and you think there's no way that I could possibly play that. And then I just remind myself, it's like with skills or music, it's just notes that are in a certain order. So I just ask myself, can I play the first note? I can play the first note. That's kind of like the location that I'm going. Can I play the second note and just turn it this way? And if I can play the first note, I can play the second. Now can I play the first, the second, and the third? And by the time that you reach the end, as long as you start from the beginning every single time, you've mastered most of the rest of it. So that's why I think about any new skill is how many little easy chunks can I break this down into? A lot of people like to use the term micro skill, and then you just take it slow. You just focus on the order. It's slow, focus on the order, and then you eventually build speed. And then with music, there's kind of this cool thing where it's if you learn a whole piece and you learn all the notes in order, you're not confined to that one piece. You gain the ability after you have some speed with it, you get comfortable with it, you gain the ability to improvise with it a little bit as well. Did I get that approximately correct with the parasternal long axis? Is that the way you break things down too?
Yeah, and to play into that same illustration, the song you're trying to learn or the sound you're trying to replicate. And so if you play those notes and it just doesn't sound like what you're aiming for, you may be on a fret, right? Or maybe you're not holding enough pressure. And that plays into the same when you're looking for a parasternal long. You know what it should look like. And that's what you're trying to get to. But sometimes you got to make a little bit more of a rotation, or you got to, change up the positioning a little because everybody's heart is in a different place. So knowing this is what I'm trying to get. This is the image. This is what a parasternal long should look like. And then taking what Dr. Weimersheimer talks about in this episode are kind of like those corrective steps to go, oh, maybe my guitar's out of tune. Oh, maybe I'm hitting a fret. And you saw his guitars in the background too, so it's perfect illustration for that. But I
liked his Telecaster. Oh, I should have put my Telecaster in the background because I love Telecasters. I want to know what kind he has. I couldn't see the top of the stock.
Yeah, really, really nice. And I think that watching this, even if you've been doing ultrasound for a little bit, some of the mental models that he gives are excellent. So yeah, I think you guys will enjoy this episode. Dr. Weimersheimer, the first time I saw you was, I believe it was Castle Fest during COVID when it was all online, and you were presenting some tips and tricks to getting a better cardiac view. So before we get into that, just tell us a little bit about yourself.
Sure. Tyler, thanks so much. This is going to be a lot of fun. Thanks for having me on. Peter Weimersheimer. I'm an emergency physician. And if you can tell by the gray hair, been around for a while. I actually started doing point of care ultrasound in 96 in our ER when Angie DeWitt's rolls in. I remember it was an Aosote cart. But the whole idea back then was, how do you use bedside imaging to really transform trauma care or critical care and emergency medicine. And so I've been involved ever since. And yes, Castle Fest, Tricks of the Trade for Cardiac. And as we've talked about, and the impetus for doing that type of a lecture is that I taught at Castle Fest for years, and we always taught cardiac. Everyone wants to learn about the heart. And the challenge of cardiac scanning is that you can learn at the bedside, you get the lectures of what it's supposed to look like. And then when somebody's scanning by themselves, figure out what's wrong with the image and what to do to give that image enough clarity that can make a decision becomes challenging. So I evolved from doing, hi, here's how you do basic cardiac scanning, to here's how you go backwards when you have a picture you don't like to get the picture you want. And that was a lot of fun to do that.
Yeah, it's kind of like when you're going into to intubate, in paramedic school. You just bury it in there, you see it right away, and then in real life, you go in, you're like, I don't recognize anything. So there's like these steps that you take to try to optimize that view, and that's really what I wanted to do with this episode. Because some people may be listening or be unfamiliar with the terms. I know you got your probe right next to you. When we talk about rocking, fanning, rotation, could you just give us a quick primer on that before we actually get into the discussion?
Sure. And one of the main things, or one of the basic tricks of trade, I think for many people, is to not do too much at once. Right? If you think about the heart's kind of a funky shape, it's not in the chest in an organized way, right? It's not consistent. So when you put a probe to find your image, you got to figure out where you are. And so the good news is that if you do certain motions independently, it makes it easier. So a couple of things you can do. I'm going to get my probe in the middle. This is me learning how to get on the screen. So the basics, this is sliding, right? So sliding, you're just moving on the skin surface, and you're trying to find something you can recognize. And I always talk about the target initially as a sonographic landmark. Find something that you recognize. Because once you do that, then you can dial in what you're looking for. So the other thing that we talk a lot is the concept of fanning. So if you imagine that there's a flashlight beam coming straight out of this probe, it's really skinny facing you now on the screen, and it's really wide in this direction. Fanning is when you take the probe and you just go like this. And what's that doing? It's pushing that flashlight beam through from that one point across a target in this orientation. So that's a fan, and a fan is really nice. Once you've kind of gotten the view in the axis you like, that fan lets you really dial in the biggest part of that structure you're looking for.
And I think real quick, so with fanning, would you say that that's kind of like, on a CT, how you get a bunch of slices? It's just changing up the slices?
Right. Well, so, the CT is doing this. It's doing a slide. The slices are all vertical. So again, when you slide, you're doing that CT slicing. When you do the fan, now you're slicing kind of at a diagonal to a perpendicular to a diagonal. And again, for lung scanning, we're not even talking about lung, but the secret of getting a really nice set of A-lines is to get your probe perpendicular to pleura. Patient doesn't look like SpongeBob. They have a round chest, not a square chest. So when you're on that chest wall, you got to do this because you don't even know where that perpendicular pleura is. But back to cardiac.
Yeah.
So the other thing that we do is rocking. And so rocking is the same idea. Look at that ultrasound gel on my probe. It's dirty. But if you go like this, that's a rock. And you can imagine the flashlight beam now is going this direction to find the target. So one of the cool tricks of the trade, just at the basics, and we've done those, we haven't gone to rotation yet, is that if you're scanning and you happen to glance down at your probe and see it's like this as you're scanning your target, or you see it's like this as you're scanning your target, remind yourself that the best image you get is when your probe is vertical and perpendicular over the target. So one thing that's really important, if you see that you're getting your target like this, that's great. You tell yourself, okay, for me to get a better picture, I'm going to slide to where I'm pointing and get my probe like this. Now all the sound waves are coming back into the probe. You're getting a brighter, better picture. When you see this, I'm going to slide over to be vertical. And now all those sound waves are coming back. And otherwise, some Martian is watching you say, hey, dude, that's a pretty cool heart, but I'm seeing it more of it than you are. The final thing is rotating. So rotating means you have that two-dimensional beam, and you don't know exactly the orientation of the structure in the body, so you can just dial this way until you get the axis you want. So like in a kidney, long axis looks like a kidney beam. Short axis looks kind of like a circle. Blood vessel, long axis looks like a rectangle. Short axis like a circle. Parasternal long axis looks like a triangle. Short axis like a circle. So that rotation is what dials in the image to be really crisp and have the shape you like. So typically with scanning, it's going to be that sequence of motions, and depending on which target we're talking about, which one do you do first? And in general, it's a slide, probably a fan, then a rotation, a dial, and those little subtle things. But if you do those sequences over and over, it makes it much easier to get that specific cardiac view that you're trying to get.
And I liked in your lecture, you talked about when you bisect a cone, and even thinking of it like a cylinder, if this is the, the cylinder and you have it right down, you should get a pretty perfect circle, right? However,
Correct.
if you have it angled a little bit, you get more of an oval shape.
Right.
And so you could look at it and be like, man, that left ventricle looks really small. Look how tiny that thing is,
Yep.
And then it's just moving it just a little bit to get the better view. And commonly you hear like the difference between like a really crappy view and a good view is just a slight like movement.
Right. So it's a great point. And focus, saying the left ventricle, that's the key to success with cardiac scanning. We'll get there in a second. Mm-hmm. But I think the idea, again, early on when you're scanning, I use the term window shopping. You're just trying to find
window shopping,
right? So you're moving all over the place, and not too fast. But when you see the target, at that point, now you're talking about a little bit of sliding, a little bit of fanning, a little bit of rotating. It's amazing when you're dialing in an image, when you realize how much 1 or 2 degrees of a rotation makes your image pop, or 1 to 2 degrees of a fan makes your image pop. So the idea is that initially, it's gross motor movements, find the target you're looking for, get your probe over the target, and then you're just dialing it in. So, and I guess back we're talking tricks of trade. One of the most important tricks of trade for cardiac scanning, we'll go do a few basics in a second.
Yeah.
As you mentioned, is that LV. And I'll be the first to tell you, I think people neglect the RV. So in resuscitation, we can talk for an hour about right ventricular function as an important thing for resuscitation. But for getting an image, focus on that LV for a bunch of reasons, because the LV is it's much more consistent structure than the RV, and it is, in theory, a cone. So if you bisect a cone in half, you should get a triangle. So for the parasternal long axis view, for the subxiphoid, for the apical 4, the goal of all 3 of those images is to bisect that LV. So in those images, you want to see a nice triangle, and we'll talk a little bit in a bit how to get that. And the
Yeah.
parasternal short, it's bisecting the cone in the short axis. So that's the one view where you want the LV to be a beautiful circle. But if you remind yourself that the goal of your scanning and that image is to include a triangular LV, it just simplifies the world. It makes it much, much more intuitive how to get the picture you want.
All right, so let's do I'm going to give you a scenario that I
Ooh.
think everybody has encountered before. Let's say I got a patient who is tachycardic, and I'm wondering, is this tachycardia due to just them having a hyperdynamic LV, needing some fluid, or they actually have like a poor ejection fraction, and that's why it's compensating? Trying to guess if I gave that ventricle more fluid, would it eject more fluid? And so I'm going to go do a parasternal long. So I got my clinical question. I throw the probe on. I go down to like the third or fourth intercostal space, and I'm looking with the probe marker towards the right shoulder. I'm setting it all up for myself. I know the heart is always angled this way. I know it's always right here. And I get in. I'm right next to the sternum, and I just don't see anything. The heart's not where I was taught it was going to be. And so, you do, let's have the patient take a breath, and I just can't see anything. What happens? I mean, why is that heart not in the spot where everybody says it's supposed to be? And how should I troubleshoot that?
Well, isn't it frustrating that the patients in the real world that you care for aren't your standardized patients at a course, or not that plastic mannequin with the S dots that you can use in a sim lab? So the main thing is that what's beautiful about people, we're all different. Mm-hmm. And so for any person, where their heart is in the chest is going to vary a little. Sure, it's supposed to be the third and fourth rib space. Would be nice. But especially with elderly patients who have COPD, there's a lot of variation. And so there's really two things that are crucial to getting a nice parasternal long. Number one is figuring out where the heart is in the chest. And you actually have that in your handout, which I love. This is what I do as well, is I'm going to try and use it myself. Can I do it? Sure, why not? I have my probe here on the left side of my chest. So instead of going here where you can't see, go up by the clavicle. Take that probe, nestle it right into the clavicle, next to the sternum, kind of set your angle. And then with a ton of gel, we'll get back to gel, just start sliding down. And when you slide down, you're going to see a bunch of air because it's lungs. You see a bunch of junk you don't even care about. And all of a sudden, you'll start seeing some black. That's fluid in the LV. And so typically, the first rib space that you see an image, that's probably the perfect rib space to get the parasternal. You may not be getting it exactly right, because at that point in time, then I'll do that fanning, right? So typically, I'll slide down, I'll see that black area. Cool. Take a break, pat yourself on the shoulder, and then I'm fanning to try and see if I can get the LV to show up, and typically the aortic valve and the mitral valve to both be in view. Might do a little bit rock so I can get that aortic valve over the mitral if I can, or slide a little bit back and forth like this, but that usually dials in most of the LV and the parasternal long the way you want it. So the first rule, I call it slide to the prize. Just start at the clavicle, just head on down towards the feet, and you'll find it. It's there. Everyone's got a heart. And what's really amazing, like when you're doing this and you're practicing, you'll be sliding going, this guy doesn't know what he's talking about. I'm not seeing anything. And all of a sudden you're down by the left nipple. You're down by inner space 5 or 6, and all of a sudden the heart shows up. Mm-hmm. And you're like, who knew? Right? It's like, where's a diaphragm on a chest, right? To put a chest tube in. Holy crap, it's up at the armpit. Like, who knew it's there? So yeah, number one, do that nice slide from the clavicle down, be patient. And when you see that black, you first get it, then mess around a little bit with fanning, rocking, try and dial in most of the parasternal long. The second part that happens is not only do you not know where the heart is in the chest, but even though you think it's in this orientation as you were describing, you can try and feel a PMI, but good luck, right? It could be any angle in the chest. And some people have the heart angle like this, some it's like this. You don't know. So that's where the second part is, to focus on the shape of the LV. So I've slid down, I've fanned to get the valves, I've kind of rocked to get most of the LV in my picture, just like I want to see for a parasternal long. Again, you don't need to get the entire LV in the picture for a parasternal. But then I take the probe and I'm watching the screen, and I rotate the probe and I watch the LV. If the LV gets longer and pointier, fantastic, I'm going the right direction. If the LV gets shorter, oops, wrong direction.
Mm-hmm.
And then you just rotate to get that nice pointy structure. And then when you look at your parasternal, it's just like the textbook. It looks great. So slide to the prize, rotate for a triangle. Those two movements, fantastic.
And after I watched your lecture talking about that, it clicked, and I liked the fact that it gave some variety as to where the heart may be, right? So I went in, I had a patient, I'm like, I'm going to try old Weimersheimer's trick out, and I put some gel down, right here, and I put my probe on, I'm angling it, and I start sliding down, and by the time I got to where I should be, I ran out of gel. And so I was like, oh, I feel like he may have talked about this, but are you supposed to draw a line with it? Do you just put as much as you can right here? Like, what are you doing?
So let's back up just for a second for everyone about tricks of trade for cardiac scanning.
Yeah.
Cardiac scanning takes a ton of gel and it takes a ton of pressure. And so if you think about it, when you do a subxiphoid, for instance, you're pushing down here against skin. When you're doing apical 4, you're in a rib space.
Mm-hmm.
So you can see how if my probe is angled like this in ribs, there's part of my probe that's in air. Mm-hmm. Like air doesn't conduct sound waves. So anytime you want to get a good image, whether it's parasternal, subxiphoid, apical 4, ton of gel. And so I'm not shy. I have a lot of fun with my patients. I do scorched earth. I'm like, hang on. And man, they're like, what the heck? You just dumped a bottle of gel on my chest. I'm like, yeah, because it's good for your skin. But in reality, it's great for scanning. So to your point, if you're going to slide the probe, you got to have gel. And let's talk about probes. So a hand gel probe, and they're not only this brand, but handheld probes that have batteries in them get a little bit warmer because that's where the power source is. And so they'll heat up a little bit. Heat and gel don't really work together because the gel gets thinner. So even with a conventional probe, a conventional handheld that doesn't have power source, any probe you want, you need gel. But one of the reminders, if you have a handheld with a battery source, if you're getting a good image and all of a sudden like, wait a minute, I was getting a good image and it's not so good, more gel. Because it's gotten runny. Just put some more on there. So long answer to a short question, but absolutely just go scorched earth and scan your brains out. Don't worry about the gel.
Yeah, so I like that a lot. And it makes sense, you think about the heart, and I don't know, I can flip the orientation of the screen, but like you think about the heart, it's angled like this down towards, the left side. And so starting up at like the sternoclavicular notch here and angling it and then going down. And then I remember you said once you got it, dial it in and then just little rotations until you bring that into
subtle stuff.
Yeah, just right into the picture. And so that's been a game changer. That's worked really, really nice. And so What I like about that is typically if I get a pretty good parasternal long, I've set myself up if I want to go to a parasternal short. I can just flip that probe marker over to the other side and try to get a perfect circle. So what are some of the pitfalls you've seen when people try to go to the short? And should we be trying to get a long first and then going into the short, or just start off with a short if that was our goal?
Great question. And for everyone listening, when you think about cardiac scans, there are 4 scans, right? There's a parasternal long, parasternal short. There's a subxiphoid apical 4. You'll get more familiar with them by breaking them into 2. So the parasternals, you're spot on, Tyler, that parasternal short, it's in the same place. You don't have to slide to the prize anymore because you're there. You're at the spot. And so the focus to go from a long to a short is to rotate. I was going to quickly take a break because the question is, why would you want to go from a long to a short anyways? Like, what's the difference? So a parasternal long, and maybe another trick of the trade as we're bouncing around, thank God you can edit this, is... So there's no requirement that in the field you need to do all 4 views of a cardiac scan, right? Your goal is clinically getting enough information that you have something about your patient's cardiac function that affects how you think about your resuscitation. So a parasternal long is a great view. I didn't say the F-bomb.
No,
it's a great view, right? So on the right side so first of all, the ventricle is going to be pointed to your left of your screen. Just get used to that. Ignore the dot. We'll get back to the dot later. On the right side, you see the giblets. There's the right ventricular outflow tract, the aortic root, and the LA. They should be the same size. This is the view to ask the question, is there a thoracic dissection? Because this is the view you're going to see that dilated aortic root. You need a dilated root for a thoracic dissection. Fantastic. Then you can see the aortic valve and the mitral valve really well. Are they moving well? Simple yes, no question. Cool. Then you move your eyeball to the LV, and it's a great view for LV function. Fantastic, right? And an LV function that's normal is 60%. You mentioned hyperdynamic. I was just at a course where someone asked a question, isn't hyperdynamic tachycardic? It's a kind of funky word, but hyperdynamic means that when you look at the LV, there is less than 40% of fluid left in it. It's dumping up. There's less filling and less volume left. It's a volume depleted term versus a speed term. But you can get to see the LV, and the LV is 60%. Boom, move on. You drop your eyeball and you look below the pericardium by the descending aorta and see, do I see fluid? If it dumps into the aorta, that's pericardial. If it goes below, that's left pleural. But the main point is if you see normal giblets, normal valves, normal EF, normal no fluid, that's a great study. You don't have to do anything else, right? Really. The problem with the parasternal long and the short to a degree is that it doesn't really assess the RV.
Right.
So if you're concerned about RV size and function, not so good. And frankly, I was going to say about pericardial effusion, not a lot of studies in this, but if you think about it, on the parasternal long, the probe is here, the heart's here, the pericardium base is here, you're looking down, water flows downhill. It's an amazing view for effusions.
Yeah.
So for that blunt trauma patient, I want to know pretty early on if I'm seeing an effusion, because then I'm concerned about a thoracic injury. I use a parasternal long. I've seen effusions on a long that I have not seen on a subxiphoid. Okay, so now if we move to a parasternal short, the goal is to see that ventricle in short axis, a circle, and what's nice about that circle is between the LV and the RV is interventricular septum. And so the short axis view is that really nice view to quickly assess whether the pressure in the LV is higher than the pressure in the RV. It's a circle. As soon as the RV starts having pathology, too high volume, too high pressure from an obstructive shock, for instance, that septum starts flattening. So the reason you would want to go to a parasternal short axis view is you want to get a little quick information about the RV relative to the LV. So that's a cool view, really fast. And to your point, you're rotating 90 degrees. And the most common pitfall is that when people rotate, they kind of drop their hand. It's just natural, right? So you're rotating. So I always recommend slow your processing down, keep that mitral valve in view and try and rotate on the mitral valve just as you would do if you're doing an IV and you're rotating and changing the plane of your vessel. If you see, the typical thing when you drop your hand is you're going to see the aortic valve. Like you see this, it's like, wait a minute, I'm not seeing the ventricle, I'm seeing this funny valve. That's beautiful. It just means your hand fell and you're going to sweep up to the mitral valve. And ideally you want to sweep up to the papillaries because that's where that fibrinous annulus is. You get that nice circle. So that's probably the most common pitfall. The other one is that people just slide their hand. And so way back to your question, I know the audience is like, this guy's been talking for 5 minutes straight.
No, this is good, man.
I can't even remember the question, but the question was, what do you do if you can't get the parasternal short? And I think you were spot on. I think going back to the long again, dialing that in, and then rotating your hand again works really well when you're starting out. So either the most common thing is that the tail is going to drop down, and you just kind of slowly angle that tail through the aortic valve, through the mitral valve to the papillary muscles, or you've slid a little and you got to just get that probe back up. Probably the easiest way when you're starting out is go back to the parasternal, dial it in, and then slow your processing on that rotation. That usually works great. And on the parasternal, it's also a great view for pericardial effusions. And it's a great view for wall motion abnormalities, but that's complicated.
And I that's why I like, I mean, besides what you were saying about looking at the crescent shape of the right ventricle and your D sign and seeing the pressure variations between the RV and LV, I like to look at, like, let's say I have a a STEMI transfer that we're going on,
Right.
and I see that they have inferior ST elevation. I mean, even though you're like, okay, I still want to look at the heart with ultrasound. Even though I know we're going to a cath lab, people will be like, well, what is that going to change? I've seen some of those that have presented like ST elevation, and then you look and it's actually a thoracic dissection, dissecting into the coronary artery. And, you could get a great idea of what that is looking at a peristernal long. You see a dilated aortic root, and you're like, okay, I think that's what this is, and then you see maybe a little effusion, and you're like, okay, now I really know what this is. However, sometimes that's not the case, and I just like to correlate to train my eye looking at wall motion abnormalities in the short axis and then looking at how that relates to the ECG. And it's just very easy for my brain to think septal, inferior, anterior.
Yeah.
That's an easy way of me to, or an easy way that I can think through that. So just to recap what you said real quick, I start off, I typically just start off at a peristernal long because that's kind of my, do I need to look at a peristernal short question? So it naturally leads from one to the next. So I go down, I get my short, then I'm going to, once I get my long, once I get a nice view of the long axis, it looks like a triangle. I try not to drop my hand and I rotate over to the left. However, if I did drop a little bit, I'm pointing up. So it's going to maybe get a little bit of the aorta in the shot. And so straighten it out. And then I'm moving down, but I'm not moving straight down. I'm moving kind of at an angle because that's how the heart is kind of angled as well.
Yep.
And then I'll see this like flickering, right? And you're like, okay, I'm right where the mitral valve is. And to look at like the mid left ventricle, I just got to get right below that mitral valve. And then I can start to see those looks like the two little twins in there, the papillaries hanging out. And that's, if I got a nice circular view in those two papillaries, I'm in the right spot, right?
Yeah. And, and a fantastic point about the differential of somebody with atypical chest pain. So if you have a STEMI, it's a known STEMI, absolutely, dissection will knock off one of the coronaries. So you can have an LAD that's based on the dissection flap going through the coronaries. That happens. Mm-hmm. So your skill set, I'm talking to all of you in the audience, your skill set, for instance, going on a transfer from a facility where they may not do bedside echo to a facility that's receiving is you're getting a little more information about the patient in front of you that maybe thrombolytics may not be the right choice, like putting a thrombolytics on a dissection. And we've had QA cases, M&Ms, where that's happened, right? It was a STEMI, chest pain, bang, thrombolytics, oops. There is blood around in the pericardium, probably not the right decision.
They got heparin, aspirin, Belinta, everything's on, and then you look at it. And a lot of times, to your point, they don't get a chest x-ray, right? They go, oh my God, STEMI, ship them out. They don't have anything really leading them down that thought process.
And all the radiologists close your ears. But let's call a spade. An x-ray, it's probably slightly better than your clinical exam skills, but not much.
Yeah.
So the point is that you can actually see an alternative diagnosis for chest pain sometimes. Fantastic. It's going to change management. Number two, to your point, if there is a STEMI, put that probe on the short axis view and look how the wall motion changes in a vessel distribution, right? You have the circ, you have the RCA and the LAD. Take a look at that short axis view, and it's the best view. I think it's the best view to see wall motion easily. Mm-hmm. And the third is sometimes you're going to have an atypical chest pain that's being transferred because they want high level of assessment, and you put your probe on and you see the wall motion abnormality. It's pretty fun to call up the old cardiologist and say, hey, by the way, this patient that has a normal EKG and you haven't gotten a troponin back on has an LAD. They think you're pretty smart. So
as paramedics, they go, stay in your lane.
No, they'll say thank you. But the idea is that's how powerful the tool is in your hands. So understanding that people stay in your lane, they go, whatever. When you know what's going on with your patient, especially during transport, it makes your life better. It makes your care for your patient better. And who cares what they want to do on arrival? They can do every test known to mankind, but you had framed your patient, you had framed your management, and you're ahead of the game. So keep on doing this on your patients and start, normal is normal and it's easiest to learn. But as you learn these positives, it's a lot of power in your hands to be confident in what you're doing, but also to sometimes change what the intervention is going to be on arrival.
Yeah, and you can predict patterns. Even if, like you said, when you get there, they go, "Well, we're going to do our own 12 lead and our own." They probably
Have at it.
should. Yeah, but it helps you predict patterns. And I have a class that I teach, and I have this guy who comes into the ED, and he's got ST elevation and like anterior lateral leads, and his blood pressure 70/40, and I say, what do you guys want to do for this guy? Obviously, we know he needs to get to the cath lab. We know what his definitive treatment is. It's clearing that cardiac lesion. And almost everybody says, I'll start 250 ml bolus, right? Let's give him a little bit of fluid. A cup of coffee never killed anyone.
Yes,
And
it
so
did.
they start thinking through that process, and I pretty much get everyone to agree, right? And then I throw an ultrasound probe on, and I show them this huge dilated LV. The mitral valve's not even close to the septum. And I said, even though usually the audience doesn't know anything about ultrasound at this point, I said, if I gave that left ventricle more fluid, do you think it would eject more fluid? Universally, everybody says no. And I'm like, this is the same patient that we were just about to dump 250, 500 mLs in. And quickly, you just used ultrasound to make that decision, right? Because yes, you can use it for codes. And, that's like the safe way. Do I see beating or no beating? Okay, we can
Right.
call it. I'm not going to end up on the news. But there's so many other clinical questions with that I think is super important. And every time you pick up that probe, you have a question that you're trying to answer. But that right there, to your point, even if they're not going to do anything about it, you look and you see that little subtle ST elevation or that inverted T wave in AVL actually equates to inferior wall motion or inferior wall motion abnormalities.
Right.
Then you're predicting, okay, are they going to get bradycardic? Are they going to drop their blood pressure? You just start thinking through things a little bit differently.
And you frankly, you start getting the habit of looking, right? Because to your point, what if you put the probe on the chest and there's a big RV, right?
Mm-hmm.
Like LVs actually, we know if you have a big dilate LV, if you gave it 200 cc's, it probably wouldn't make a difference, right? The LV is just this big L muscle. It's just not working well, but it doesn't really care about getting 200 cc's. You have a big dilated RV that's being stretched to its limits of function. You dump a little more fluids in there, and now it goes from being somewhat dysfunctional to catastrophically falling off the cliff, right? So, again, another scenario is an atypical chest pain patient who's actually having a saddle embolism. So their vital signs are crappy. They may not be necessarily hypoxic, but if they have a big RV, like that's changing if it's an isolated RV dysfunction, like, oh, maybe this isn't primary cardiac, right? You can spill troponins for a lot of reasons. You can spill troponins from big RV. So again, the habit of looking and just confirming what you have in front of you, what your choices are for resuscitation en route, it just becomes a normal routine and a positive routine to really affect patient care.
And some of my favorite cardiac ultrasounds I've seen of a PE are when there is that nice clear parasternal short and you can see the septum starting to bow into the left ventricle a little bit.
Right.
And then the other one is the apical four chamber. I really like an apical four chamber because it gives it just a great overview of the heart. Here's the problem though, Dr. Weimersheimer. I suck at the apical four view. I'm terrible at it. And I recently saw a video that helped me quite a bit with getting it, and I want to pick your brain and tell me what you think of this technique, okay? So keep in mind, this has been the view that I've avoided because I'm just not that good at it. I'm in Wisconsin where everybody's, eating a lot of cheese and stuff, so it's hard to get in there sometimes. But I watched, and I cannot remember who it was. It was it was a video with like 50 views on YouTube. But a woman was saying that she gets a parasternal short, right? So let's say I go from my long to my short. And if you go too low on a short axis, how it starts looking tinier and tinier and tinier because you're getting down towards the tip of that cone. And then she said once she gets down to that apex, that smallest point, she just fans it up a little bit.
Yep.
And I was like, whoa, okay, now turning a short into an apical four, that seems way easier. So I did it on myself and I was surprised. I was like, that was the easiest I've ever gotten a 4-chamber view on myself. And I've tried it on patients and it seems to work really well. However, I've never seen anyone else teach it as taking that short down to the apex and then just fanning up. What's your thoughts on that?
It's a great technique. I think back to reality of patients, and especially patients who eat a lot of cheese. I think the reality is for a lot of patients, you either get really good upper windows and lousy lower windows, or you get good lower windows and lousy upper windows. So I have a little bit of a different technique, and which I'll go over.
Yeah.
And part of that is, for number one, the apical 4, absolutely my favorite view. And there's so many ways that the apical 4 it just changes management, because you can not only see the relative chamber sizes, you can see cardiac function for both the RV and the LV. You can see how the valves are working, and you're perpendicular, so you actually do color jets across the valves. So really sweet view. And the good news that even for the biscuit or cheese challenge patient population, that lateral chest wall actually is typically doesn't have as much BM mass as center or farther axillary. So where the PMI is actually a relatively thinner area of tissue on the chest wall. So I like to think about doing the apical 4 in 5 steps. I always love 5 steps. So this is my 5-step rule. And again, I'll preface that beforehand is number one, tons of gel, and you got to push hard. I can't tell you how many times, and you've been that experienced teaching, somebody's struggling with an A4. I'll take my hand on the probe. Not supposed to do that. And I'll just put pressure on the probe, and the image gets better because you got to push. Another thing that's really important, and I'm going to use, is I like to talk about the ultrasound handshake. A lot of people hold the probe up here, and ultrasound echo techs will hold it here. They scan 8 hours a day. Get used to putting your hand on the chest and then putting the probe in your hand and having that hand anchoring, because one of the challenges of an A4 is that you're on the side of the chest, the patient is sweaty, they're covered in gel, your probe's going to slide easily. And to your point, you're going to be sliding off a parasternal short. You go, oh, that's a cool image. And the next thing you know, you're scanning their navel because you've slid all the way down to the belly. So basic things, before you even think about scanning, you're going to have tons of gel and pressure, and you're going to hold your probe low and anchor it. Hold it like a pencil and anchor it. So the way I do it is I start really primarily looking for the A4, so I don't go from a different view. And part of the reason, if I'm struggling for a parasternal short, that's going to limit me going from the parasternal short to the long, to the A4. And some patients have a tough window for the short. You're not going to get a short easily. You have to be prepared to be humble with cardiac scanning. So number one of the tip is find the beating thing. I know that sounds crazy. Like, yeah, everyone's got a beating thing. But a lot of times people will scan in the chest and they'll be lower than they think they need to be. And they'll be looking, saying, I don't see a heart. I'm like, the heart's up here. So you slide up. So take the probe, transverse orientation, dot towards the left of the patient, and slide up in the mid-clavicular line. In a man, it's typically to the left nipple. In a woman, it's typically to the left breast fold. That's where the heart is. It's pretty high up for that view. So number one, you're just going, sliding up, find the beating thing. Fantastic. That's step one. Step number two, dollars to donuts. When you're mid-clavicular, you're going to see a diagonal heart on the screen with the apex off to the right of the screen, right? So you got the heart, but it doesn't look anything else like the picture. So number two is just get that apex of the heart in the center of the phased array pie. And one motion at a time. To do that, you are doing a slide. And typically it's a slide towards the left of screen, or left of patient. So probe is there by the left nipple on a guy, left breast fold in a gal. And then I'm going to slide towards, usually it's towards the left, every once in a while towards the right, until that probe is centered in the pie. Fantastic. You're 2/5 there. The next thing, the diagonal is going to be towards the upper right of the screen. If the diagonal is towards the upper left, flip your dot over 180 degrees. And the reason the dot that's on a diagonal is that you're trying to bisect that heart exactly in half in the same axis of the heart. You want to be like this, but you're probably like this. So if you can see how my probe is to this axis, what would be the solution to get that probe straight on the septum?
I'd have to rock it.
Exactly. Step number 4, rock the probe. Rock. One motion. Rock the probe, and it's always to the left side of the chest. Always. So you've slid the probe, and now you're going to rock the probe to the left side so that probe is parallel with the axis of the heart. and that septum becomes vertical. And you might have to slide a little bit and rock a little bit and play around, because when you rock and move, it changes your place in the chest.
Right.
So I just do that back and forth a little bit. And then, so that's step 3. You've now dialed in your apical 4 that the septum's on top. The apex is on top. The septum is vertical. So you're almost home. Typically at that point, if you want to look at the shape of the ventricles and the atria, you want to see all 4. A lot of times you'll see kind of a wide set of ventricles and maybe not much of atria. And what that means, and you used the word earlier when we were kind of just bantering before we started about foreshortening, it means you're probably steep. So you're getting on the ventricles, but you really want to get through the apex so it shines up to the atria well. So number 4, try to pull that probe down, or maybe even pull it down a rib space. So I've gone up, I've slid laterally, I've rocked, and now I'm just going to pull down or even slide down a rib space to see if I can get that long set of ventricles and I can see the atria. All right?
So put your hands just like they just were for a second. I want to ask you something. So I know because you're scanning it like this, your hands are more so like rounded around the probe. But if you were scanning someone else, would you recommend not having anything underneath the probe so you can get that shallow?
On an A4, you won't have to get that shallow. If you're going to get that shallow, you're going to be doing apical 6 or some weird thing.
Because I know on like a subxiphoid, it's sometimes very hard to get in there.
We'll get to the subxiphoid. We'll go to the subxiphoid quickly. So on an A4, I would not keep I think, again, ultrasound techs hold the probes like this, and they're usually at the head of the bed. If you're that good at scanning and controlling your probe motion, pick the motion you want. In general, much more consistent, holding probe like a pencil, keep that head anchored, and I'll be like this. You are not going to get lower than this on an A4. I've never had that issue. So that's cool. Everyone's got this. We've gone 4 steps. You find the beating thing, you slide to get the pi, apex in the center of the pi, you rock to get the septum vertically, and then you pull down the fan to see if you get that long ventricle and the atria. Fantastic. And number 5 is really the same for a parasternal long or a subxiphoid, is what's the shape of the LV? And for the apical 4 and the subxiphoid, do you see both valves? Because dollars to donuts, when you are exactly transverse, you won't see both valves, and the ventricle will look a little egg-shaped. That's normal. The good news is that in almost every body, like I was saying how with carts can be variable, the solution, again, you want to focus on the shape of the LV. Remember the rule. If the LV is a funny shape, the cure is a rotation. And in a cardiac scan, you're almost always going counterclockwise 5 degrees. I can tell you 95% of the time, you'll be on a transverse. You almost have this perfect apical 4. You go like this, rink. It dials in, and it is just, you sit there and go, that is a great picture. Patta. Patient's dying, but dude, I got a great apical 4. So I think that when I've taught that and when people practice it, I think that way has worked really well, because you're not relying on getting from one image that might be hard to get to another. You're just focusing on the steps cognitively to go from nothing to finding the heart, to getting the apex, to getting the vertical septum, to getting the ventricles, and then to rotating for the valves. And those are all single motions. So try it out. We'll check back again. You see but I have found personally, it works for me. I still do that. I've been scanning for 30 years. I still do my 5 steps. I joke around with my patients. I'm going to find your heart. They think, what? You know where my heart is? But
do you have a video of you doing that? Like showing that on a person?
I can share that with you. Absolutely.
Yeah, that'd be awesome, man. Because, listening to it, I see what you're saying. I just think that sometimes a visual of seeing what that actually looks like when you're doing it helps a little bit.
Yeah, this is banter. But I do, but for all of you listening, the idea about the 5 steps is that it keeps it very simple. So you're going to have to practice. You have to try out those hand motions. But it's cool when you're scanning a heart. When you slide back and forth, you'll say, oh, yeah, that's really cool. That apex is just flying it out of my image. Fantastic. When you rock the probe, you'll say, oh, cool, that ventricle apex is now the septum is going sideways to vertical.
Hmm.
That's cool. So those two muscle memories of what your hand motion has done to your image, you got that, and that works for every structure in the body. And then you'll go, oh yeah, when I go down longer, that fat ventricle becomes longer, and I can see the atria. And then for cardiac scanning, over and over and over, if the LV looks like an egg, if you can't see the valves, you're going to rotate the probe. It's a single step, and you'll do it. Again, 5 degrees counterclockwise. It's really fun. You'll be scanning and go, okay, he said 5 degrees, let's chocolate. And you're going to go, rink, and you go, damn it, he's right. It worked.
It worked.
It worked. So absolutely. Well, let's, offline, I'll share some of my graphics with you, but for everyone listening, the idea about this is it keeps a complicated shape and structure in the chest, the view, attainable by just doing single sequence of steps. And back to the sliding off the subxiphoid, the parasternal short. Great. I know people who like to go from the subxiphoid. I know people like to go from the long, because when you slide off a long, you get a backwards apical 4. Then you got to rotate your probe. Whatever you do that you learn that works for you, fantastic. I just personally have had a difficult time trying to get someone to learn off of a different image, because then if they don't get the image they're learning off of, then they're SOL. Right now they don't get 2 images, and we just want to get 1, right?
Yeah. Well, and that's what I was going to ask you is, I'm sure that there's probably no view that the Peter Weimersheimer can't get, and you can't get somebody's heart. But for a lot of us, let's say I got a 25, 30-minute flight. I'm doing this. How long should I be messing around trying to get a view before I say, you know what, I'm going to try a different view? What would you say in your practice? Because there's got to be some patients that you're just like, man, there's like no window, right? You called it window shopping. What is a reasonable time? What is a reasonable time? And I know it's probably dependent on the patient. Are they crashing and et cetera? But I'm sitting around, I'm messing around trying to get this view. I can't get it. I add more gel. I add more pressure. When do I bandit it and try another window?
I move pretty quickly. So if I try a parasternal view and I'm not getting a good upper window, I'm again understanding that many times, for some, just anatomically, the upper windows and the lower windows can be really disparate. Like you get lousy upper windows. So if I'm struggling to get a parasternal, and the issue is when you're on a med flight and you have if you have a vented patient and you're positive pressure, like who knows where the anatomy is now. I will typically move quickly. I try to get an apical 4 almost immediately. That's my favorite view. A subxiphoid, we'll talk about in a second, is the identical view. You get almost identical information. So I'm going to go ahead and pick, first of all, I think, back to which one do you use? There's probably one that you feel most comfortable with. Like you may be really comfortable with your parasternals. I'd probably mess around with that a little bit longer because that's what you're good at.
Yeah.
I like to go to an apical 4. I'm really good at apical 4s because I've messed around with them for a long time. So that's kind of my go-to. And to the point of which one do I get, you're trying to get one initially that gives you some information, especially if your patient is crashing, to focus on your patient and manage your patient. And then depending on time, depending on cadence, sure, go back and try and get a better picture, get a different view. But initially, I want enough of one view to say, I think I understand what's going on, and I think being humble, and then I'm going to focus on my patient again. Then I'll go back in and play around and try and dial another view. The goal initially is, what's the clinical question at hand? Am I getting enough information from the view I got that I can make an educated decision about resuscitating my patient? And then do I have time to look for other views in terms of the resuscitation cadence? So I guess back to the question, go to the view you're most comfortable with.
Yeah.
And when that doesn't work, go to the view you're most next comfortable with. Go to your 2 money shots. And one's going to be high, one's going to be low. A lot of people do a subxiphoid because they learned on EFAS, and that's their view. That's fine.
When do you mess with your gain?
Always.
Are you always messing around with it? Or do you get the image and then do it?
Well, call a spade, right? First you want to, and I always talk about this, like back to window shopping. I always use the term, I had a great anatomy teacher, and he loved to say this: focus, general to specific. So for instance, let's go to a subxiphoid. everyone struggles with subxiphoid. So what's the biggest barrier to subxiphoid? Oftentimes the depth isn't enough, right? That heart is you're going from the sternal, the base of the sternum up to the heart. That could be that's like going from Earth to Mars sometimes. So if you have your probe set at 15 centimeters, you're not going to see the heart because you're not deep enough. So first off, I'm going to do a subxiphoid, 25 centimeters, 30 centimeters. I don't care. On my butterfly, I'm just zipping the screen up. Then I'm putting the probe under the chest, and we'll talk about some of the tricks of trade to get that image. But then once I see the heart, and this goes for any imaging you're getting, once you get the heart, then adjust that depth to get that heart right in the middle of the field, because that's going to give you more clarity. You get better resolution. And same thing with gain. Once I get so to your point, I start scanning at what I think the right depth is. But then once I'm close, I'm going to adjust my depth, because the more that structure's in the middle of the field, I have higher resolution imaging. And then I'm going to mess with gain, because more the gain is at the level that I like it visually, I'm going to see more stuff that I would miss if I was undergained or overgained. And then I'm going to work on dialing in my giblets. So people forget to do that. They forget to dial up gain. They forget to dial up depth. Sometimes they're scanning in a preset. For instance, let's say you're in an EFAST preset. That's not the best for cardiac imaging.
Right.
Switch to a cardiac preset. Or maybe you want to do the IVC and the subxiphoid, and you might get a better view in an abdominal preset. So the idea is, don't just rely on what you got. Get close to where you are, and then ask yourself the question, self, if I mess with a few things, could I get a better chance of getting the image that helps me out?
Yeah, typically I would say my rough goals are the fluid inside the left ventricle, inside any of the chambers should be black. Right. I mean, it should be black, but I don't want to dial that down so low that I lose echogenic borders and I lose some of the information I'm getting back from the mitral valve. So I dial it down to try to make the fluid black and not lose any of those echogenic borders. Would you say that's okay?
Yeah. Again, you're you. And so whatever tricks of trade you do in dialing your gains up or down, it's a little bit based on the question you're trying to ask. So, for instance, let's go back to a subxiphoid, right?
Yeah, but you've been doing this since '96, so you got way more experience. So what Tyler does is probably very different.
No, what Tyler does has to answer the question for Tyler. So if you have a sequence of thought processes that's going to get you where you want to go, that's yours. So, for instance, let's go to subxiphoid. The subxiphoid was one of the early described point-of-care images in the EFAST, or actually back then it was even the FAST. We even didn't think about lung back then. And so everyone popped the probe on, and the question from the subxiphoid was only, do you see the liver? Do you see the RV against the liver? And is there fluid in that space? That's it. That's all you're doing for a trauma evaluation. That's a primary survey. That's the ABCDEs with ultrasound, right? Do I see pericardial effusion? Yes, no. And you move off it, and then you go to the belly. So let's go back to the subxiphoid from a more complicated question. If that's the only thing I care about, I can adjust my scanning to just see that interface. All I want to know. But then if I have a question about cardiac function, and maybe that trauma patient who's hypotensive is not because of the traumatic injury, maybe they have a cardiac issue, right? Then to your point, I'm going to focus on seeing the fluid in the ventricles. I'm going to focus on dialing in the angle so the ventricle shape, the RV and the LV and the valves look correct, because I can say, is the LV functioning well on its own? Is the RV functioning well on its own? Is the RV 2/3 of the LV, or is the RV bigger? Then I start dialing in those other questions, so you adjust your scanning sequence to answer the questions as you have more questions. So a couple of things about the subxiphoid, back to tricks of the trade. I think you mentioned this way back earlier. It's the one time you tell people to get their hands on top of that probe, right? Because you're popping off to look up. A couple of things I see a lot of people struggle with is, I think a lot of the teaching was go put the probe on and slide up. One of the problems with putting a probe on the belly and sliding up is you never realize how far away you are from the sternum. Number one. And number two, if you slide up a little bit to the sternum, there's this thing in the middle between the probe and the heart called a transverse colon. And Tyler, here's a board question for you. What's inside the transverse colon?
Air.
Air. Exactly. Right? So you slide up off the belly, you get to where you think it's just in the heart, and you see a bunch of you see nothing. And you're like, where's the heart? That's because the transverse colon is in the way. So what I love to do for my scanning, I love to teach it this way, is instead of starting the belly and sliding up, and my patients actually have fun with this, I take that probe, and if this is the xiphoid process, I put the probe on the xiphoid process. I take a ton of gel. I pile up a huge amount of gel here. I'm on the xiphoid process, and I tell my patient, hi, sir, hi, ma'am, I'm going to pop this probe off your bone. I'm going to get it to your chest, and I'm going to try and jam it to your right shoulder. And they look at me like, you're what? Have a little fun. But the idea, now this is what happens. Think about this. When I slide off, I'm pulling down tissue, and the way you're going to get a good image is to get a nice seal of this probe face to the tissue. So that's where you want that gel. You're popping off, and when you push upwards, you're really sealing the probe against skin. You get a beautiful image because your probe is nice and tight against skin with gel. So if you're sliding up on the belly to here, like if you're down over here, here's my xiphoid process. As you're sliding up, first of all, you're losing your gel. There's your transverse colon. You don't even know exactly where you are. So again, back to the ultrasound handshake. I'll put my hand on the patient's chest. I'll say, this is where I'm going to put my probe. I put the probe there. My patient knows it. And they're prepared for me to pop off and push hard. Mm-hmm. So that's number one. Number one, a lot of depth. Number two, pop off the xiphoid process. Don't slide up from the belly. Then the issue is, even with doing it that way, sometimes you don't see the heart. What are the things you can do? It's counterintuitive. Number one, you can slide a little bit towards the right because that's where the liver is. If you catch that liver edge, it'll be a nice acoustic window. Sometimes that works. Sometimes it doesn't. You can have the person flex their legs so that relaxes their belly wall. So if they're asleep, if they're intubated, I'll pull their legs up. If they're awake and they can move, I'll have them flex their legs for me. And the best trick of the trade is if the patient's awake enough, I'll ask them to take a breath in and hold it. Mm. No, dollars and donuts. I'm saying dollars and donuts. That's my word of the day. The phrase.
I like it, man. There's lots of dollars and donuts here.
Lots of dollars and donuts. When the patient breathes in, that pops that diaphragm and heart, and like literally, you're scanning, going, I don't see a heart, and all of a sudden, bloop, that heart just pops into view. Just pops into view. A thing I always teach. This is what I used to do. I get really, if you can't tell, I get really excited about ultrasound. So I'd be scanning some patient, and I'd say, hey, can you hold your breath? And they do it. And I'm scanning away and I'm pointing it out to a resident or a student, going, check this out. And then I look over and it's some 83-year-old little old lady or little old guy who's going, and I've learned that when I tell a patient to breathe in, I breathe in and hold it as well, because usually when I'm ready to pop, they are as well. If you have a patient on a vent, don't tell the medical director. But if you do an inspiratory breath and shut the vent off for a pause, you have 30 seconds of a little hypercarbia, but incredible scanning time to get the image you've always wanted. So that's a great trick of the trade. A cool thing. So subxiphoid, parasternal, apical 4, a breath in will move that heart down a little bit. If you're scanning a parasternal view, one of the scourges of parasternals, you'll see lung in the way, right? You see that air, and you're going, what do I do? And if your patient's on a backboard, it's hard to roll the left lateral decubitus. Yeah. Remember to do the opposite. If you have a patient where you can't see the parasternal lung well because there's air in the way from the lung, have them exhale and hold it for 10 seconds. And that exhalation will shrink the lungs up. You get a beautiful parasternal. And just hold your breath at the same time so that they don't turn blue on you in that view. So tricks of the trade. You're doing a parasternal and you want to get a better image and get rid of the lung. That's an exhalation. You're doing a subxiphoid especially, and you can't see the heart well and you want to get in a view. That's an inhalation. It's just physiology, using the patient you have to help you get a better picture.
No, that makes a lot of sense. I see the subxiphoid very common, and I'm sure you do when you're out teaching EMS for cardiac arrest, right? Because it's low, you got a lot of people up at the head, and if you're using the Lucas or something like that, or the auto pulse, you can't really. It's hard to get in there, right? Yeah. So that's typically where I see the subxiphoid used. And one of the things that I think is important, or I've at least seen, is that you're putting the gel on, but then people are also wiping it off. So if you are doing CPR, it doesn't turn into a slip and slide. Correct. Is that would you say that's your go-to view, that or an apical 4 chamber for cardiac arrest?
Well, especially with the Lucas, right? So So again, two things for cardiac arrest. One is you're doing an ultrasound briefly during a pause just to see if you have cardiac activity or not, if you have pseudo PEA versus PEA versus standstill, right? So the cool thing is, we've defibrillated fine VF that by monitor and exam is a cardiac arrest. But when you do that little pause, you see a little bit of quivering of the valves and go, crap, that's fine VF, blast them and
Mm-hmm.
they're fine. But the second part of cardiac arrest, and this is a little controversial still, is that if you look during, let's say you have a Lucas on board or you're doing mid-sternal CPR, when you get that subxipher apical 4 view, the goal for me is after, if I like to try and actually keep the probe on and see if I can see the cart during compressions.
Mm-hmm.
Because I'm going to be looking and seeing, is it the LV that's being compressed or is it the LVOT? And unfortunately, where most CPR is performed initially in mid-sternum, that's actually the LVOT. So again, a subxiphoid or an apical 4 is a really nice view that if you can get that during CPR, so sometimes you have to be a little lower, a little more depth, but if you can see that LV and you're watching chest compressions, I ask myself, am I seeing that LV being compressed? And in our world, in our system, I'll have the person doing the compressions move their hand towards the left chest and watch that LV start compressing. And we do that with TEE, which is easier.
That's what I was going to say. That's where I first really saw, I think his name's Felipe Turan, did some studies looking at transesophageal echo and compressing the LVOT. And
Right.
I tell people sometimes I feel like I'll sneak it in by the plunger and I'll look to see with just a little bit of fanning, I can get a decent view, even on a transthoracic ultrasound of that
Absolutely.
LVOT. It's hard to tell that in a lower view, like an apical 4 or a subxiphoid. It becomes harder for me to see if you're actually compressing the aorta because you're
Correct.
compressing the LV and you're on the same plane with
Yeah.
that. So my traditional method is if I come across and let's say they're doing actual CPR with their hands, that's almost the best because you can move that easier than having them move
Yeah.
a Lucas device. And then once I'm getting really good end tidal CO2, and I can see that I'm not compressing it, I'll make a little mark there to know to put it in that spot. And then after
Sharpies.
that's, Sharpie or something. And
Yeah.
then once the Lucas is on and that's working, I'll do a little circle. So if it starts looking like a kaleidoscope or something, I know that, we're meandering, we're moving around or whatever. But, in the same vein of cardiac arrest, the other thing I've noticed is I've learning this, over the last, I don't know, 10 years or so. And I was always thinking big RV equals pulmonary embolism. And then I started noticing in cardiac arrest, almost everybody has a big RV. And I couldn't really use that to correlate PE or differentiate PE from just the patient being in a low flow state and having cardiac arrest or being in cardiac arrest. Have you noticed that
Yeah.
as well?
Oh, yeah. And that's described pretty well in the literature. So I'll back up very briefly. One of the things about if you have a patient where you're going to put a Lucas on, there's a, you have to grab the Lucas. So there is that session where you can try and find out where the LV apex is really quickly. And to your point, I love Sharpies. They are the bang, draw an X. But that's one way to kind of get a framework of where's the heart in the chest. And Lucas's move as well. Like when you have a Lucas on for a while, they start sliding all over the place. So as you're doing your kaleidoscope, right, you can mind yourself where you should be. RV, absolutely. So there's a lot of newer literature that's not so fast on a big RV being a PE. You see a big RV all the time. And there's myocardial stunning. There's all different, and physiology of why that is. So the idea is that you have to be humble. So you may have a PE. Where's the best place to look? Go down to popliteal fossa, see if you see a
The
clot,
legs.
right?
Yeah.
Right, look at the legs. But initially, to me, what a big RV tells me is I'm very conservative about fluids.
Mm.
Right? I don't know why the RV is big. If the patient is having if they're not contracting, all bets are off. If the patient actually has cardiac activity, as you were describing an LV that's dilated, if I see an RV that's dilated, I'm really nervous about messing with any filling pressures. So if I was going to do a resuscitation protocol, I'll be more interested in using a pressor. I'd be a lot more interested in just being very judicious about how I framed volume versus pressors. That's what it tells me initially. It doesn't tell me initially, especially with an arrest and ROSC. When the ROSC happens, I don't know why that RV is big, and I think that's been a controversy of what to do with that. So to me, it's more of a great on ROSC, great on cardiac activity, caution on what you choose for your resuscitation protocol, right? Don't go giving 500 cc's of saline specifically for that patient. Maybe they need to be diuresed, right? Maybe that's the problem. There's all sorts of stuff for that.
Have you looked into the reason behind the RV getting big? Is it because the EF is terrible, but you still have some venous return? Is it because of the positive pressure? What's the consensus on why that gets big?
I'm not familiar with any specific consensus. So I'm not quite in that critical care space. There may be more of a consensus now, but I'm not familiar with that. There's a specific rationale in terms of physiology and why that is. But I think your point is really important, that just because it is big doesn't mean that it's big from one specific pathology. The fact is that it's big, right? That's a really important.
Yeah, I'll put up a picture of like a big plethoric fat IVC, and I'll say, what does this tell you about the patient? And I have they have pericardial tamponade, they're fluid overloaded, they have a pneumothorax, cardiogenic shock, or that they have an elevated right ventricular pressure, right atrial pressure. And it's like, I'm like, imagine you're getting on the highway and the traffic is backed up. You have no idea if it's backed up from an accident or just congestion or whatever. So really can't just look at the IVC by itself and then try to come up with a cause for it. One last thing I was going to ask you is, and I know sometimes I will get the IVC in the cardiac mode just because it's easier to do that. And I will just try to get a decent view of the IVC while I'm in that, as opposed to something like an abdominal mode. What mode are you using for the IVC?
I guess it depends on your system and what it's what you prefer imaging. I actually like an abdominal setting on the IVC.
Okay.
I like to focus on the liver, and I like a little less of that dynamic. I like a little bit of a higher dynamic range, and what dynamic range means, I'm seeing better grayscale. Again, if you're comfortable going in cardiac mode and flipping off the RA and getting a nice IVC shot, fantastic. Personally, I just like the grayscale for me. I like to look at the hepatic vein coming in, but it depends on how busy I am. Like if it's busy, I'll just flip off I'll take the cardiac setting, I'll flip off, I'll grab the IVC. If I want to go back and do a little more nuance, or if I have a little slower processing, I'll switch to an abdominal setting. And again, I use a probe where I can just bomb back and forth really quickly. It just takes me 3 seconds to switch. And a caution about the IVC for everyone when you were talking about a big RV. Right, the IVC, you want to be. I counsel not to use color, use anatomy. Right, the IVC's got to dump into the RA. If someone has a big RV, they can have chronic cor pulmonale and a chronically big RV. You're going to get retrograde flow through the tricuspid valve. That IVC can look exactly like an aorta. If you put color on it, you can get color flow that's going towards the feet that kind of reminds you of the aorta. So great to do that rotation, see that IVC going into the RA, seeing that hepatic vein coming in, and slow your processing down that you're taking care of the right tube, because the aorta will be going behind the heart. Another trick of the trade that I do, I will get a long axis view of one of the tubes. If I'm on a tube and I fan my hand towards the left of the patient, the tube goes away, it's all I see, that's aorta. I'll fan back to that tube. If I fan to the right and all of a sudden another tube pops up, that's IVC. And so the trick of the trade for me is anatomy. The IVC is on the right side, aorta is on the left side, IVC goes into the heart. Don't get lulled into submission by trying to do color. If you can get that view of the IVC going into the RA, that's optimal. If you can't, camera 1, left, camera 2, right, camera 1, left. Just like use that sweep back and forth to convince yourself that when you decide the IVC is plethoric and big, that you're on the right vessel. The opposite is sometimes you'll see the aorta and you'll know it's the aorta and you don't see the IVC. That's because the person's dry and you're pushing down, you can't see it. So just use that, again, back to humility and scanning, but just slow the processing down and say, is the vessel I'm looking at the correct vessel? What are the ways that I can quickly make sure I have the right vessel to make my right decision?
Awesome, man. Well, Dr. Weimersheimer, thank you so much for coming. This is super helpful, man.
This is fun, man.
This was more self-serving for me, I think, than anything. To be honest with you, I wasn't even recording this. I wanted to trick you into talking with me no, I'm just kidding.
No, thank you so much. I didn't really do my hair for the recording, so I knew you were going to do that. So,
hey, real quick, is that a PRS behind you?
It is a PRS Custom 40.
Nice. Is that a Telecaster guitar off to the other side?
It is a Telecaster off to. Oh, yes. This is actually a GNL set when Leo Fender started Fender in the 50s and made these really cool windings on the pickups, and I think got somewhat disenfranchised with how the Tellies had evolved. So he started making GNLs where he did old windings again. So this was a guitar with old windings for that
awesome.
that sound.
I love a good Telly. Well, I'm sure we'll do future collaborations. But really big thanks. Thanks so much for coming on.
Yeah, Tyler, what you're doing with this is wonderful. Thank you all in the audience for listening in. And Tyler, thanks for what you do. And for all of you, scan. This is great patient care, and this is fun. And this has been fun to be on this podcast with you. So thank you so much.